a teen is using substances. How do you decide what kind of treatment makes sense? Outpatient therapy? A more structured program? We're breaking it down.
Welcome to the Carlat Psychiatry Podcast. I'm your host, Dr. Josh Fader, the editor-in-chief of the Carlat Child Psychiatry Report and co-author of the Child Medication Factbook for Psychiatric Practice, 2nd edition, 2023.
And I'm Mara Goverman, a licensed clinical social worker in Southern California with a private practice and an avid reader of the Carlat Psychiatry Reports. Today, we're discussing how to determine the appropriate level of care for teens with substance use disorders. Deciding on the right level of care involves looking at substance abuse severity, co-occurring conditions, family support, and the teen's engagement in treatment. So, Dr. Fader, when working with teens, how do you start thinking about treatment options?
One option is to start with outpatient care if the substance use is mild and the teen has strong family support. That typically involves weekly therapy, often family-based, and sometimes medications that treat co-occurring conditions like depression, anxiety, or ADHD, or medicines that can reduce craving of substances. But when kids need more time in structured care, intensive outpatient programs or IOPs are a good option to think about. These involve 3 to 5 sessions per week while allowing the teen to stay in school and at home. So I've had lots of kids in IOPs, and I'm so grateful for them because the kid can stay in school. You know, they don't have to sleep somewhere outside of the home, and they're getting several days a week, multiple hours, in those afternoons.
And the family's getting support.
So to me, so many times I see kids who were trying to do motivational interviewing, something like that. We'll talk a little bit more about that later. And if it's just not working, IOPs are a great next step.
One of the challenges I recall over the years in co-treating with you are the teens who are using marijuana and not wanting to stop, and yet it's a problematic issue for the family and their lifestyle. And as a psychiatrist who works in a private practice, I wonder if you could comment for our listeners, how do you begin that discussion?
Oh my God, weed is everywhere, right? And there's other substances, right? But in our practice, weed and alcohol and nicotine, which is like even more addictive than about anything else we got going, is a problem. And honestly, the thing that haunts me the most is fentanyl. So it's really the risk of getting whatever it is, weed or some other pills that you get off the street, and so many of them contain fentanyl, and it's like one and done. I mean, literally dead. And then the everyday worry is the kids who love their weed, and that's ubiquitous, and they don't want to stop using it. And so all our work on motivational interviewing can work if you are pretty good at it, and it can work over time, because you and I have shared cases where people have been using for like years, and they come to us, and then it takes another couple years, and then they're not using. Just had another kid do this 3 weeks clean this week and feeling a little bit better. But I've been working with this guy for 4 years, and finally we're at that point. So it's a long-term process, really challenging. And getting somebody like that to IOP when they're not actually, malfunctioning enough.
Or not available.
Or not available. So the IOPs might not be available, and the person might be just not wanting to go. It's hard to push them. So you're right. There are a lot of challenges with it, but honestly, when you can get somebody to an IOP, it's a godsend because it takes a weight off my shoulders for a while. I mean, they come back right from the IOP after about 3 or 4 weeks, but it's still a very useful approach.
I just wanted to touch base on one thing that became an issue many times for you as a private practice doctor is, when do you begin medication if someone is continuing to use substances?
Yeah, so there was a time in my practice where someone was using, I wouldn't treat their ADHD, whatever it was. And I'd say, well, why are we doing this if you're not clean? Because weed is a great example of one that the withdrawal makes you depressed and you're going to keep smoking and I'm going to be treating your depression. And I understand dual diagnosis, right? I mean, we've been talking about that for decades and I've been around for decades. But why bother? I mean, why am I wasting your money and my time in a private practice where a million people want to get in when I don't think I'm going to get anywhere? I shifted that because I wasn't winning those battles at all, right? People were just continuing to use. And so now I'm more assertive about trying to treat co-occurring conditions. But honestly, that came with the advent of my increasing skill, I would like to say, in motivational interviewing, because if I can get someone to think about, what are the things that they get from using and what are the things that they're trying to get in their life and how might the substance be getting in the way, that conversation goes better when you are co-treating whatever it is. And some of these medicines can then reduce some of the craving. That's for a more extensive discussion.
If substance use is more severe or there are acute mental health concerns, a partial hospitalization program, or PHP, might be more effective. These provide daily structured treatment while the teen continues living at home.
IOP is usually a few weeks, and then insurance is like, they can go back to outpatient. Same thing with PHP, although the step down from PHP is often IOP, right? The PHP, so they're missing school. Usually it's 4 or 5 days a week, but then they cut it down to like 3 days, which is weird because then what's the kid doing when they're just at home? To me, it feels a little bit at risk. But in any case, there's a place where they can be. And again, they don't have to be sleeping in a hospital, and they do bring schoolwork in. So you don't always get totally behind. But if it's a choice between residential and trying to do a PHP first, I would totally try to do a PHP first. And again, no program is perfect, and you always get kids complaining, oh, I'm bored, we're not doing anything. But the truth is that the outcomes that I see in my practice are generally pretty good, where people are more likely to be clean for those few weeks and more likely to be more amenable to whether it's IOP or outpatient afterwards and continuing to work, because it does give some time to the process of that motivational interviewing process, meaning understanding where are you in your life, where are you going with this, where is it going to lead you if this doesn't work, that sort of thing. So it's a bit of a, come to Moses moment.
In your experience, do you anticipate that you have to go through PHP programs more than once?
Like with adults, you usually need, several cycles of inpatient, maybe for a month or two sometimes before it takes. I see substances as having almost a life of their own in the psyche of the person. They make you want to use them. It's like an imp or some other kind of demonic
alter
presence.
ego.
Yeah, something. But anyway, it makes you want to do it, and it takes a long time to get to a place of fortitude to be able to say, okay, well, maybe this isn't so good for me. Maybe I can't step away. I mean, there are some people who just step away, but that's not the majority by a long shot. So it is challenging, and people do sometimes run through PHP a couple times before you have effects. And similarly, if you fail PHP a few times, well, then we're starting to talk residential treatment. So when a teen's home environment is kind of part of the problem, if it's, kind of disruptive, if people have mixed feelings about using, because a lot of parents are using, right? Or if they're struggling with ongoing use despite all these outpatient kinds of care, well, then we need to think about residential treatment centers, RTCs. So these programs are basically, you live there. It's round-the-clock care for several weeks to several months. And again, back in the day, we would send people to RTCs for a couple of years at a time and, let them grow up more safely for a while. And, maybe they wouldn't get into more trouble or, God forbid, die from some substance-related or other psychiatric-related problem. But these days, you can't get payment for more than a couple months at a time. And ironically, now the substance use with particularly the fentanyl crisis is more deadly than it was before. So we're in a fairly precarious position with that. But again, I've sent a lot of people out to RTCs. My feeling about the research on them over the years is that they're mixed in terms of outcomes. A lot of times you get there, you're not using for months, you're behaving better, whatever, you're not causing as much trouble. But then when you come back, if
Very hard.
Well, it's really hard. I mean,
to
re-enter because you want to try to work with the family while they're there. And most programs will do that, but they come back to very much the same environment. And so within a few months, a lot of times people have regressed again. So then some people will send somebody out to like a therapeutic boarding school, sometimes for a few years, if they can afford it, or if a school district will cover the cost. But RTCs, again, I think they have a place. Now, I will say that we have a lot of people who might be adopted or have other attachment issues. And I think you have to be really careful about sending someone with an attachment problem history out to an RTC. It's kind of sending them away again. So I would be careful about that because that can make it very hard to work with them. And again, to reintegrate them later on.
Rounding out the options, inpatient treatment should be considered for teens at acute risk of severe withdrawal or in severe immediate distress. And finally, there are some schools that have school-based substance abuse services that integrate education with substance use treatment.
Yeah, so that kind of rounds out all these different options, and that's why it's so bewildering. Obviously, acute inpatient is the thing most people think about when they think outpatient or maybe IOP or maybe they need inpatient. But we really do reserve that for people who are in some sort of acute situation. And I have a lot of people who I think they would be better off inpatient when they're withdrawing from whatever it is, even weed. But getting someone in for that, again, if they're not acutely suicidal or
delusional, the marijuana sometimes.
Well, actually, I'm glad you mentioned that, Mara, because the psychosis rates we used to say were about double, but they're probably more like quadruple because of the high potency of THC. So that's an instance where you can probably get someone in and maybe detox them. And that does happen a lot. And of course, teens and young adults, that's the age when we see this anyway. We've got a whole issue in the spring of 2025 coming out on psychosis, some of which talks about that. And I'm working on another specific piece on actually autism and substance use that'll be coming out in a little bit as well that might be of some interest. So there's just so much around that and things that could get you to inpatient care because of added complexity, severe depression and psychosis, that sort of thing.
I just want you to comment about emergency rooms and teens who come in because they're having hallucinations, delusions, or other physical manifestations that or increase their health risk.
Well, that's right. I mean, one of the top differential diagnoses of somebody come in with a psychotic condition in an ER, if they're a teen, is substance use, whether it's they were, tweaking on some sort of amphetamine or weed. Even overuse of caffeine containing products is another big one. And so there's a lot of things that can do it. So yes, important to be ruling that out. And of course, you're ruling out organic reasons, et cetera, et cetera. It's complicated. It's always complicated. I also wanted to talk a little bit more about the school-based programs. Honestly, I haven't seen a whole lot of impact from those programs, but I haven't seen a whole lot of those programs. I think the research, we're still waiting to see what that's like. The problem, in part, I think it's this idea that schools might be able to take over care when the people who are at the schools are often beleaguered. They have too many kids.
Overworked and undertrained.
Undertrained. Thank you for mentioning that. That's where I was going next with this. They're just not necessarily built to be able to manage, severe addiction at school. But people want to try that because they don't want to hospitalize people. They want to keep people at school. The worst of those was, back a few decades ago when people were, doing Red Ribbon Week, I think they still do it, and saying, just say no, which didn't work. It just cost millions of dollars to, create the program and roll it out. So I am hopeful that school-based services can be effective, but I feel like there's more to go in terms of trying to develop those in a useful way. And look, I'm a proponent of school-based services. We do an anti-bullying program that has been effective for kids with differences, not so much focused on substance use. So I know it's possible, but I think there's just more to go on that.
When choosing a level of care, you can use the American Society of Addiction Medicine, ASAM, criteria, which consider 6 dimensions.
So, yeah, these 6 dimensions are substance use severity and withdrawal risk,
So that's high withdrawal risk may point to inpatient care,
Co-occurring conditions,
which includes depression, anxiety, or ADHD that affects recovery that may require PHP or RTC.
living environment,
A stable home can support IOP, while an unsafe environment may indicate residential treatment required.
social environmental stressors,
Academic or legal challenges may require more structured treatment.
engagement in treatment,
Teens might not always agree to care, which affects what options are realistic.
and finally, family and social support.
Caregiver involvement plays a very big role in treatment success.
The framework helps guide decision-making, but engaging the teen in treatment discussions is actually very beneficial. Motivational interviewing, which we mentioned before, can really help. And these techniques, which we've actually published on before,
These include expressing empathy toward the teen to help build rapport and use reflective listening.
and as an example, you might say something like, it sounds like you're frustrated with people who love you telling you to stop smoking. And then the next principle is to develop a discrepancy.
Raise awareness of teens' current behavior. Help them to identify differences between goals and values and current behavior, and encourage the teen to come up with ways to adjust behaviors to align with stated values and goals.
So you might say something like, I hear that you enjoy smoking, and yet you're worried that your little sister will start too. What do you think are some ways to prevent that from happening? The next one is to avoid arguing or confrontation.
Reframe the statements and acknowledge ambivalence.
So you might say, I hear that you're not ready to change your smoking behavior. What do you think would be helpful if and when you're ready to make a change? The fourth principle that we talk about in motivational interviewing is to support self-efficacy.
Explore past successes in other problem areas and apply to present situation. Provide strategies and resources that can help assist the teen with change, and affirm that the teen is able to choose and carry out personal change.
So you might say something like, you were able to get in shape and make the soccer team. This is kind of the same. If it's okay with you, I can share some ideas that have worked for other people that might help, and we can also think about other ideas together. You can do this. And then finally, supporting autonomy.
Reinforce that agency. The power for change lies within the teen versus counselor, teachers, or parents. Listen as the teen develops an action list of steps to change behavior.
So you might say something like, you have some really great ideas about how to make some changes. We can continue to talk together as you figure out how you want to do it.
I find that when teens feel heard and involved and supported, they're more open to engaging in treatment. And aftercare plays a big role in maintaining progress.
We do have a lot of examples of this, and I want to refer listeners to our webinar that we put out about a year ago on motivational interviewing for substance use. And it's got, my goofy cartoons and a whole bunch of examples of different people where we're using different stages of motivational interviewing, like pre-contemplation and contemplation and planning and relapse, things like that. So we'll put that in the information for this episode so people can take a look at that. But the takeaway is that there are multiple levels of care for adolescent substance use treatment and no one-size-fits-all approach. Clinicians, caregivers, and teens all play a role in shaping what works best.
Thanks for joining us for this discussion. It is inspired by Dr. Dhruv Shah and Dr. Brady Heward's article from our January, February, March newsletter.
Everything from Carlat Publishing is independently researched and produced. There's no funding from the pharmaceutical industry.
Yes, the newsletters and books we produce depend entirely on reader support. There are no ads, and our authors don't receive industry funding. That helps us to bring you unbiased information you can trust.
I hope this conversation helps our listeners make informed choices. If you found this discussion helpful, subscribe for more episodes on mental health and psychiatric care, and please share it with others who may need to hear this message. And remember, when we look for good things, more good can follow.